everyone. It's good to have you all with us this morning for the next in our webinar series, where we'll be discussing the pathway to a global standard of care for cochlear implants for adults. Now, this morning we are very fortunate to have Holly Teagle, the Associate Professor of Audiology at the University of Auckland, and also cochlear implant surgeon and the chairman of the Northern Cochlear Implant Advisory Committee, Michel Neeff. And what we'll be discussing is last year Holly was part of an international panel of ENT and audiology experts from 13 countries who were charged with developing consensus statements in relation to the care of adults requiring cochlear implants. In total, there were 20 statements developed, and these were broken down into 7 categories, which I thought both Holly and Michel could walk us through today, and what these mean for adults in New Zealand. So Holly, I think it would be appropriate for us to start with you. So can you just explain to us, give us a brief overview of the Delphi consensus process and how it was conducted?
Yeah, thank you. Thanks to Pindrop for making this forum possible too. This is important information to be out there for consumers and for professionals in this area. So it's really wonderful. I would just like to say that this effort was supported by a broad group of people. So manufacturing, all the different cochlear implant manufacturers, as well as advocacy groups and professional organizations. So it was really a broadband kind of effort to get this underway. And basically what it was acknowledgement that cochlear implants are underutilized in the adult population, and there needs to be more consistency and consensus in people's knowledge and understanding about what the pathway is to get a cochlear implant, who's a candidate, and how to refer. And then also, you know, it's all based on evidence. So there was a process of reviewing literature that had been published since 2005, and there were over 6,000 articles that were originally included, and it was narrowed down to just around 100. And these are articles that had scientific evidence of the benefits of cochlear implants, and so they support these statements that we're going to talk about today. And so the idea behind it is this is an international consensus, so it reflects global practice, but the idea is to for each country to exploit the use of this consensus to try to raise the bar and make implants more available and known about in New Zealand. So that's our mission.
Fantastic, Holly. I mean, it's definitely a fantastic initiative because we haven't had this before, and it really is as a sector, you know, something that's so vital, you know, to meeting the needs of our clients. And Michel, I think like the World Health Organization has noted the prevalence rates of hearing loss are increasing a lot at the moment. And, you know, what actually is the rates at the minute? And delving a little bit further into that with the rates, what's the percentage of those with severe and profound hearing loss? And of those, how many would benefit from a cochlear implant and who are accessing? So we're quite delving right down into the, you know, itty bitty of it. So can you just expand a little bit on that for us?
Yeah, thanks very much for the invitation to Pindrop in the cochlear implant program. Yeah, I mean, the WHO numbers are obviously global numbers. You know, I think the prediction is that over the next 30 years, there's going to be a doubling of patients with hearing loss. And I think we're looking at over 400 million worldwide at the moment. And that's going to be sort of doubled over the next 30 years or so. And, you know, obviously not all of those will require a cochlear implant, but, you know, if you look at the ones that have severe or severe profound hearing loss, we're looking at about 53 million. And currently, globally, only 5% of those actually get a cochlear implant. And so it's quite a small number. So we're sort of estimating that, you know, for each cochlear implant patient that we identify, there are another 20 out there who might benefit as well. You know, so If we sort of look at the New Zealand situation, we've got almost 900,000 people with some sort of deafness in New Zealand. And I don't know if you can bring up those graphs now, but obviously not all of those require cochlear implant. But looking at our situation, we've got two cochlear implant programs in New Zealand, and on average, we've got 100 patients waiting for each program. And so if you then work out, well, these are just 5% of the people that we identified, you can see that we're sort of up to 2,000 patients that we haven't identified. So it's a massive problem. So on this graph here, that's sort of from a few years ago now. It's from 2018, I think it was published. This is the female proportion of hearing loss. And you can see the sort of little black parts of this graph are the ones that have a severe to severe profound hearing loss. You can see it increases with age. It's a significant number, and we're just failing to identify them at the moment. And the ones that we identify, of course, and I think we'll talk about that a bit more later on, we can't really provide all of them with a cochlear implant at the moment because of problems with funding.
Yeah, which is, it is a big issue for us in New Zealand. And I mean, interestingly, like the first category in the consensus statement that was developed, Holly, was about the level of awareness. And clearly this addresses the only 1 in 20 adults, getting an implant. So what do we think is the reason behind this, Holly and Michel, and what do you actually think we need to do?
So I think it's worthwhile to kind of just look historically about how implants have developed and been used. We've had this technology for over 30 years, and it's gotten better and better with time. And initially it was just for people who were totally deaf, had no useful hearing at all. And over time, as the technology's improved and the candidacy criteria has sort of opened up. So we know that a cochlear implant can do a better job for someone with a severe, moderate, sloping, severe to profound hearing loss than traditional hearing aids. So part of the awareness is really to make sure that people understand what the current criteria are, and so who is a candidate and who this technology can help. And I think that the consensus, the sort of the standard of care for children, we've really evolved in that area. And children, especially in New Zealand, get excellent care when it comes to cochlear implants. If they need a cochlear implant, they get a cochlear implant. Mm-hmm. And so we have a really good support system for children, and it is acknowledged to be the standard of care for treating a child with severe to profound hearing loss. So, but we're just not there with adults. And so that's what this consensus statement is really focusing on, is awareness for adults who have steeply sloping, severe to profound hearing loss. And so that awareness is something that's not just about, again, as I mentioned earlier, it's for consumers to be aware, it's for audiologists to be really aware of what the current criteria are, for GPs and any affiliated medical providers to also know.
Yeah, I mean, I sort of agree with all that. I think, it's a problem. I mean, we think this is mainstream stuff. We know it is mainstream stuff, and sort of expect everybody else to know as well. But even amongst my colleagues, ENT surgeons, once you're out of the bigger centers and maybe you're not involved in cochlear implantation, there's still a lot of misinformation. They still think, oh, it's only for kids, or it's only for adults, or they still don't know the criteria very well because they're interested in sinus surgery. And so, we can definitely improve there. And same with audiology. I guess you agree, Holly, and there's still, there's sort of people out there who keep on prescribing hearing aids, and even when they don't really work anymore, patients still get sold hearing aids. And I think we need to do better there, informing, just making sure, and maybe even I don't know how you can control that a bit better, you know, and informing people and make sure. But I think we've always concentrated on ENT and audiology. You know, there's sort of a lot of work going, trying to raise awareness there. But I think the majority and the people are interested, audiologists and ENT surgeons know. What we're not good at is sort of spreading the word amongst the people who actually see the majority of our potential patients and clients. And I'm thinking about general practitioners, and obviously they are at a bit of a disadvantage because GP might not see a lot of people with hearing loss. And they might not realize that they're sort of looking at a patient who's an excellent lip reader, but if you took the hearing aids or if you covered your mouth, they might not realize that this patient is profoundly deaf. You know, I've had patients like that, and you think, are you really putting an implant in until you do the proper testing? And actually realize, yes, they would do much better. And then there's sort of the health services for the elderly and similar, and I think we need to do more work there. I think as a program, we constantly work on the referral process. I think there have been sort of comments made about it sometimes being difficult to get in and get the patients seen. And obviously that's a resource problem, funding problem. I think we can make it easier for patients to be assessed, maybe create questionnaires that are easy for GPs to apply, then that makes it easier. I always like that question, can you still use your phone? When did you stop using your phone? Because that gives you a rough guide when this patient sort of switched from being able to cope well with the hearing aid to possibly needing a cochlear implant. We need more of those questions.
Yeah, I mean, you've covered that really well, and it's really important. I think that, you know, many GPs we've spoken to at conference, you know, in New Zealand, I mean, the majority thought the cochlear implants were just for children and didn't actually realize they were for adults. So it's clearly an area we do need to be improving on to get, you know, the messaging out there. Definitely. So I think we'll just move on to the second category now, Holly and Michel, where, I mean, it addresses best practice in the clinical pathway, and it contains three key statements in that category in relation to detection, speech recognition tests, and age factors. So what do these actually look like in practice, and what are the future steps that could be implemented to improve the process? So I think you've already covered those a little bit, but have you anything else to sort of expand on there?
Yeah, thank you. I think that one of the things that some health providers tend to do is wait until they're certain about a referral. And the point of a referral is to get an outside opinion and to get an expert opinion. And so I think that sometimes people, they wait until they're completely convinced that, yes, this person is an implant candidate before they get referred. And kind of like Michel was saying, if you had a sort of a screening, since we don't do a lot of hearing screening in adults, we need to think about other ways that we can identify these people. And, you know, the questions like, can you use the phone, and can you communicate with someone when they're talking to you from another room? Can you understand when someone's back is you? You know, can you understand if you're in a noisy place and the speaker is near you? You know, so there's just some kind of key questions that should be red flags for anyone who works with the population, with adults who have some hearing loss. So those kinds of things can help get the referral numbers up. And then, of course, when we evaluate people, not everyone is going to be a candidate. And what may end up happening, though, is that person may have an opportunity to get a different set of eyes on them, and maybe some other recommendations about a different hearing aid or a different hearing aid setting, or some other assistive technology that might help. So the referral is really the critical first step in the process. And then, you know, we do have a waiting list issue in New Zealand, but it's important that we are aware of who in our population needs this service to really move the dial in trying to get more funding for that group. The tests that most audiologists do in the clinic are done through insert earphones. They don't typically test people with their hearing aids on, with speech materials after they fit the hearing aids. And that's sort of just a general practice in New Zealand. But those criteria are what the cochlear implant team looks at. So we want to know how well people perform with their appropriately fit hearing aids, and to that end we use speech materials, sentences, words, and so we can do a more thorough evaluation in the clinic than what most audiologists typically would do in their clinic.
Mm.
And is there any thoughts? I mean, I'm sort of on the detection side, Holly. I think there's been discussions globally about a standard hearing screening as part of a health, your warrant of fitness, if you like, when you hit 50, as you would have your other cholesterol and things like that done. Do you see that being a benefit or something that might happen in the future for adults, or not so much?
I'll toss that to Michel.
I thought it was for you, wasn't it?
No, it's for you.
Michel or Hollywood?
Well, a screening for adults. Yeah, I'm still a relative newbie to New Zealand.
Well, there is no screening for adults, of course, but I think adults need to be picked up through the other health services, and I think we have to sort of beat some of those myths as well. Of some of the adults and older population thinking that cochlear implants are for kids, or if they get a cochlear implant, then a poor child would not get a cochlear implant. And I think for anybody in the audience who might think that, hopefully not, but if there is anyone, that's not the case, because the cochlear implants for children are completely separately funded. And so all kids who need a cochlear implant get a cochlear implant in New Zealand. And the funding sort of issues are around adults. So if you think that your hearing is poor enough for cochlear implant, then you should be referred and assessed. I think that's very important to know. And I was also going to say, and as part of the assessment team, I often get sort of emails from the hearing house, and today it's very easy to request an opinion. So if you're uncertain as an ENT surgeon, GP, audiologist, I'm sure there is somebody in the hearing house through the audiology circles or ENT circles. We can just quickly flick a question to, maybe just shoot through an audiogram, and it's very easy to quickly look and say, oh, look, this is nothing. And even I've been surprised in the past where I thought, well, it's a bit baseline. You can't just go by the audiogram, and you can't just go by what you think, because the assessments through the cochlear implant team are much different, in some ways also more difficult. And therefore, flick us an email if you're uncertain or you think you're not quite there yet, and stay in touch. And with time will be sort of, that's one way of getting an opinion if you don't want to formally refer a patient.
And just one last point on this topic is it is an equity issue, right? We want everyone to have access. And so if, refer as a first step. When there's a case in question, please refer.
Yeah.
It's just very important. It's better to refer than not to refer, and and have people assessed through the process. And so that moves us on then to talking about surgery itself. So, because Michel, Category 3 refers to best practice guidelines in surgery. And so do you want to cover off those statements about best practice in surgery, and also some of the risks that are involved, and also, walk us through those risks, and also any myths that are still outstanding about CI surgery itself?
Yeah, sure. I mean, when I first started, I was sort of at the brink of changing a little bit surgery. And I think when cochlear implantation started, it was a matter of getting an electrode close to the inner ear, well, into the inner ear and close to the hearing nerve. And that's changed a little bit, because it's become a bit more, it's become precise surgery. And you might have listened to Bill Baber's webinar, who talked a little bit about this. We're now talking about soft surgery, and what that means is that we're trying to preserve the inner ear structure. And the idea there is, if you have a preserved inner ear structure and cause less scarring, then the little electrodes transmit sort of their impulses much better. And as a result, the sort of hearing gets much better. That's the sort of first part of soft surgery. And the second part is, as a result of the soft surgery, we are also able to preserve hearing. And in the patients where we did hearing preservation surgery in our program, we've got about a 70% preservation rate. So if you start off with reasonable hearing in some frequencies that are still useful, but you're bad enough for cochlear implant, we might be able to use that residual hearing by stimulating with a cochlear implant, as well as then using that hearing, the residual hearing, and put a hearing aid part to it. So the patient gets the best of both worlds, a bit of hearing, normal hearing with a hearing aid, plus a cochlear implant hearing. Overall, it's very safe surgery. You know, if you compare to abdominal surgery, heart surgery, lung surgery, we're making a tiny cut. The only reason why it takes an hour or two is because it's finicky. You're working around a facial nerve. You don't want to destroy the balance organ, and you want to go slowly and precisely. And that's why, you know, that's why it takes up to 2 hours. But overall, it has very little impact. We have very experienced anesthetists who make sure that the medical side of things are fine. And we talked about this earlier. We've got patients up into their 80s, and internationally, patients who are 100 have been implanted. So age is not a problem. It's the general health that guides us towards implantation. And I guess that sort of addressed some of the myths. I mean, people are always worried about their balance afterwards. Yes, it can be affected, but if you sort of are careful and preserve structure, then that should not be a problem. Sometimes patients are a bit imbalanced initially, but that returns to normal. I've had patients say, well, you know, I don't want to lose my hearing, and I address that, you know, even if we lose the hearing. So the 30% of patients where we do not preserve the hearing, they're still far better off with a cochlear implant than with just the residual hearing that they had. And even though it's sort of something you don't want to part with, you still be better off. Over 97% of our patients are better off with the cochlear implant alone than they were before the implant. Some patients worry about tinnitus afterwards. So it's the ringing in the ears that you can get after ear surgery, and it's often there at the start. But again, you know, tinnitus is often related to hearing loss. We're trying to improve the hearing loss with the cochlear implant, and therefore, once you start wearing the cochlear implant, the tinnitus is actually better. And obviously, this is an operation around the facial nerve, and patients are worried about the facial nerve. You will have a scan before surgery. We know where the facial nerve is. We're using monitors intraoperatively, and therefore the risk is minimized. And I have not seen, in sort of my practice, I have not seen a facial nerve palsy happening as a result of this surgery in a straightforward patient. And so, yeah, there are lots of myths, but it's a straightforward surgery now, and it's much refined and much more refined than it used to be when we first started.
Well, thank you so much, Michel. That was very comprehensive, and I think covered that category 3 really well. So that moves us on then to category 4 of the consensus document, which covers the clinical effectiveness of CI, and it contains 4 statements, Holly, which is including the timeliness of implantation. You know, how soon should we be implanting? The enhanced speech recognition, the quality of life benefits for recipients. So from both of your perspectives, you know, can you expand on the point covered in category 4? And I think, and also which we've also talked about already, is the limited funding we've got in New Zealand and how that might impact some of those outcomes. So I think, Holly, if we start with you in relation to category 4, and then we'll move over to Michel for his thoughts.
Yeah, so, excuse me, so recall that this is an evidence-based document. So it means that there's ample evidence in the literature that supports these statements. And the statements are that people do better with word understanding, hearing in social situations, have better vocational opportunities. All of those statements are supported by the research and the clinical research that's gone into this area. So anyone who has a significant hearing loss and struggles with a hearing aid has good potential to do better with a cochlear implant. And kind of to Michel's point from the previous section, the relationship that the audiologists and the surgeons have with a particular client is ongoing. And so if there ever are any concerns that arise about the implant or their person's use of it, the team that we have at the Hearing House and through the Northern Cochlear Implant Program is really tight. And so we can really take care of needs that people have that might come up, medical related needs, related to their implant. Yeah, the fourth statement. So speech recognition is better. Quality of life is better. And one of the key points is that the sooner that you get an implant, the sooner you're going to benefit from it. So the waiting for some point in time for things to get really bad doesn't make sense. So as soon as someone is identified as a candidate, the sooner they get the technology, the better results they may have. Now, that doesn't mean that people who have been deaf for or have had significant hearing loss for a long time won't benefit. They can still benefit, but we know that you get the best benefit when you have the least amount of auditory deprivation. So from the time that your hearing is really declining to the time that you get the implant, if we can make that as short as possible, it's going to give better quality of life and potentially better outcomes. But we do have, as I said, we have folks who have had hearing loss since childhood and who have struggled with it, and maybe it's progressed over time and gotten worse, and they still benefit, even if it's been many years since the hearing loss started when they get a cochlear implant.
Which is really
can I just add to that? Maybe, I mean, I guess, Holly, you would agree that here, that's where this sort of the standard of care statement becomes criticism of the New Zealand system, because we cannot provide this. I mean, we have some patients who have an acute hearing loss that we where we can provide this can sort of answer to this statement and provide a cochlear implant straight away. But the majority of our patients sit on a waiting list, and unfortunately, their sort of auditory deprivation continues sometimes for years, so we kind of, in inverted commas, fail because we have a funding issue here, and that's, I think that's something to realize and something we've been working with the Trust to improve, and the Trust has been working hard with the Ministry of Health to improve that.
There was an interesting study that was brought to my attention that was done in Australia that looks at all the factors that affect people's decision to pursue an implant, and funding accounted for about 40% of the factors. So some of the other ones were just people's fear of the unknown. They're worrying about access to resources, fear of surgery, fear of change. So, implants can be privately funded as well, and ACC also covers cochlear implants in those certain situations. But yes, there's no denying that we do need more public funding for adult cochlear implants, no question.
Yeah, and very important in this area, because it's like there's no other option for these clients it's not as if they can be referred back, for another option, is there? This is their last point.
True.
Yeah. Yeah.
And then, sitting on a waiting list, then suddenly other medical problems start kicking in, and they sort of go out of candidacy because a general anesthetic gets too dangerous. So those are all considerations which we constantly have, and we have to make some tough calls.
Yeah, and I think we're going to discuss a few more options later on in the webinar before we close. Like on that about getting implanted in a timely manner, that sort of follows on quite nicely to the category 5 of the consensus document, Holly and Michel, where we talk about post-implantation outcomes. And it's so as I think we mentioned, the amount of time that somebody has been unaided, it's better that they get implanted earlier rather than later, but it's not, if they've been without hearing for a long time, they can still get benefit. And but also factors with engagement and rehabilitation and programming. It's about maximizing the use of the technology to get the best outcomes for them. So do you want to cover off those points in the statement as well, Holly?
Yeah, and I just want to also, I saw a question pop up about the private criteria, and it's based on individual performance. So there are audiologic criteria, and that means how much hearing loss there is and how well people perform with their hearing aids. Those are the key criteria for implantation. And so we have to use some other layers of criteria to sort through the numbers that we have for public funding, but for private funding, it's really based on their hearing and the benefit they're getting from hearing aids. Yeah. So I think, so we're talking about the category 5, some of the associated factors associated. One really great thing that the Hearing House is an advocate for is for continued use of a hearing aid in the opposite ear. So this statement is about unilateral hearing cochlear implantation, so getting at least one implant. In the ideal situation, people often have the same amount of hearing loss in both ears, and ideally they'd be getting 2 implants. And that's what we do with children, because we know the importance of binaural hearing, being able to hear in noise, localized sound is really critical for development of a person. But unfortunately, you know, the low bar right now is just 1 implant for adults. And so that certainly can be a big improvement for most people, but we do recommend that a hearing aid be worn in the opposite ear. And it could be that the relationship that the fitting audiologist has with that person is maintained. So audiologists who think that, oh, if I refer this person, then I'm losing, you know, a client in my caseload, and the fact is that you may continue to serve that person and take care of their hearing needs for the hearing aid ear. So so don't let that discourage anybody from referring. And this bimodal hearing is what we call that, when you have a hearing aid in one ear, cochlear implant in the other. Usually it's a kind of a synergistic effect in that you get some of the natural acoustic information and then the clarity from the electrical information. So usually that ends up being a nice fit for most people and kind of gives them the best of both. There are a lot of individual factors that impact outcomes, and for as many different people who have gotten an implant, there are that many different testimonials about how they're doing. So if you have had a short-term hearing loss, for example, and you're able to get the implant rather quickly, you may do better because of that very short time of auditory deprivation. A lot of it depends on the support that a family person has. So, you know, habilitation for adults is really an important part of our program. And so having a partner to support someone and to work on listening activities to help retrain their brain is a really important factor, and that will impact outcomes too. So there's a number of different things. And again, I think if you're a person with hearing loss watching this and you're curious to know what it's like from a first-hand person point of view, please contact us. And we have a number of wonderful clients in our program who would be more than happy to give you their perspective. And sometimes I think that's what people need. They just need to know really what was it like. You know, everyone's different, so outcomes can be very different, but the experience of going through hearing loss and then regaining some hearing can be really an emotional and psychologically kind of draining process. And so getting another person's perspective and the Hearing House staff, we can help with that kind of thing.
I think we should emphasize maybe that even though we're sort of going by the previous statement that we should implant straight away, you know, some of our patients haven't heard for many years, decades sometimes, and we still have good outcomes with those. We still make a difference. So just because they haven't heard for 10, 15 years doesn't mean we're not going to implant them. And as Holly said, sometimes we just don't know what these factors are, and there's still research going into trying to work out and predict potential outcomes for various patients. So so don't not refer because the patient hasn't heard for 10, 15 years, so they still need a referral.
Thanks so much, Holly and Michel, on those points that were very insightful. And I think, again, that leads nicely on to the next category, actually, about outcomes, where recent research by Frank Lynn of Johns Hopkins, Bloomberg School of Public Health, and others has found a correlation between hearing loss, depression, cognition, and dementia. I mean, it is a correlation, and category 6 of the consensus document contains 5 statements in relation to these factors. So what has the research indicated, and what further work needs to be done in this area?
Yeah, I mean, you might want to bring up my presentation there again. It's I've taken a graph here from Livingston, from a publication from the Lancet that sort of refers to this a little bit, and really what it sort of expresses is an association. So not a sort of factual relationship, but an association between dementia and hearing loss. And can you bring that up, Nick?
I'm trying to find it, Michel. Just bear with me 1 second. We're having some technical issues.
Oh, okay. So anyway, so what it's sort of, so in that paper, the sort of the examination was into what are the factors that influence dementia. And I guess the first factor is being born, having your parents' genetics and a predisposition to your cognitive function over a lifetime, including dementia to a degree. And then, you know, as you go through life, there will be other influences that affect your cognition and cognitive function and memory, and also dementia. But then if you sort of blow up in midlife, what the modifiable factors are, that's a white screen, Nick, I've got there.
Yeah, sorry, it's not playing nice at the minute, I have to say. I'm sorry.
That's all right. But so if you look at that, then essentially it says that there's of the modifiable factors affecting cognitive function later on in life, hearing loss is a very important factor. It's in about has an influence of about 9% on outcomes later on in life. So it's an important factor to address and to address early. And obviously, by the time you get to a severe, profound hearing loss, and you haven't sort of stimulated with a hearing aid or later with a cochlear implant, the sort of influence or the negative influence on cognition is quite significant. Did you want to add something to that, Holly?
No, I think you said it well. I'll just, the statements are very clear that hearing loss is not a symptom of dementia. However, treatment of hearing loss may reduce the risk of dementia. Yeah. So, and that addressing hearing issues is one of the treatable options for staving dementia off. So whether that's hearing aids and or cochlear implants.
Yeah, I've shared it now. Can you see that, Nick? I've shared my screen now.
You've shared it, yes, I can see it.
Yeah, that was me, that wasn't you.
Oh, that's all right. I was beginning to go, what's happening?
That wasn't. So I've sort of moved on to the next bit, which is the depression part of things, and depression, isolation, loneliness. And, you know, as part of, this is New Zealand data, this is from our program, and Alan Giles sort of prepared these numbers, and Holly shared the graph with me. And as part of the assessment for our cochlear implant patients, we also look at this score, and that sort of looks at anxiety and depression. And in this particular graph here, you can see sort of that we assessed quality of life and social participation. And the way you read this graph is that, you know, of the sort of down here, this is the pre-implant level, and the numbers go 0 to 5. So 0 bad, no quality of life, 5 excellent quality of life. And if we just look at a patient here, there's somebody who ended up with a score of 1.8 pre-implant. And after the implant, which is on this axis here, he was above the line, which means he had an improvement. And so you can see all these numbers correspond to a pre-implant level combined with a post-implant level. And really the takeaway message is here that all patients, apart from one who was doing very well anyway, all patients had a significant improvement in quality of life and social participation, essentially at least 3 and above, and the majority around 4. And so in terms of cochlear implants in our program in New Zealand, we make a big difference with regards to that category. So it's strong support for cochlear implantation for these patients. I'll unshare my screen so you can take control again.
Oh, so you can take control because I'm working with 2 screens at the minute, so it's like it's all going.
I don't want to take over, Nick.
It's all going haywire, but it's like. But thank you for interjecting there, Michel, and saving the day. And I've got animals, of course, going off in the side corner. It's not children in this, it's animals as well. So it's welcome to working from home, and it's great. Not at the minute.
I could add just a little bit more to that graph because it really is good. And just to tell you who those people were, who those dots were. Yeah, that might be good to show it again. Of those numbers, there were 76 dots there. That may not, there's some that overlap, but there were 76 people that were included, and they were implanted within the last 2 years. And 22 of them were age 65 to 75. 11 of them were age 75 to 85, and 4 of them were over age 85. So I think when you think about that age group, so the vast majority, or about half of them, actually were over 65. And so those kinds of improvements in quality of life for our elders is fantastic. This is one of the data sets that Ellen analyzed, and there was a separate one on anxiety and a separate one on depression. And they also showed these same very impactful, significant changes for this population. So that's all I had to say about that.
I'll unshare again. Here we go.
Well, so we're back. So that leads us nicely on then to, I think, the final category in the consensus document, Holly and Michel, which highlights the cost benefits of unilateral cochlear implantation for adults. So I think, Michel, you've done a great graph on this. So if you would like to expand, first off, Michel, and then Holly can comment as well.
Yeah, I didn't produce the graph. Of course, that is sort of information shared. I'm just going to share this again. Bear with me. Here we go. Yeah, so these are the cost implications, and yeah, I mean, overall, there's an improvement in employment as a result of improving hearing and cochlear implantation. There are lots of savings, and we've got sort of economists working on these all the time to try to sort of help us make the point that cochlear implants are very cost effective and save the government tax. Costs and sort of reduce increased tax. So if you sort of look at this graph, this was produced by Kim van Lenten, who's a health economist. They produced it in 2017. And if we look at this graph, you have at the bottom, you've got the age of a patient. And this sort of looks at a 19-year-old down here on the left-hand side, and the potential tax payment, plus if this patient was unemployed and required benefits as a result of his unemployment, the government would lose out $800,000 in terms of tax. This is the cost of the cochlear implant, which obviously stays pretty stable over the years. And you can see that for most people during their working life, all the way to the 60s, there's a significant benefit for the government to provide a cochlear implant, and therefore, not providing cochlear implants actually means a big sort of tax loss for the government. And so that is sort of one of the arguments that we often bring to the government, but unfortunately it hasn't resulted in any sort of significant increase towards cochlear implants for all. But there are other benefits as well, of course. I mean, the cochlear implant, we think of cochlear implants in terms of hearing, but if you hear well, the overall balance, the balance system improves a little bit as well. So you end up with less depression, as I just showed. There could be fewer falls, mental health improves. So there are other costs, cross-sector savings that were not considered in this graph. So overall, it's a very cost-effective treatment. This is a graph from 2018, but internationally, graphs like this have been produced over the last 20, 30 years. And again, we're not meeting the standards of care at the moment. I'll share here. And our builders have arrived.
So Holly, over to you.
So I think those are great. The cost effectiveness, there's lots of evidence around this. And when you think about the cost effectiveness in terms of how it can impact, not just from a monetary standpoint, in terms of how much revenue people are able to generate in their lifetimes based on their vocational opportunities, but just the social and academic and other, personal benefits that come from having better hearing, makes that cost versus risk ratio really, really tip on the side of being a very effective intervention.
Yeah.
And I think that it really sort of leads us into those are the summary of the statements, and it's where do we go now? And it's about advocacy and information, generating information and sharing information, and it can happen at a grassroots level. Everyone who's watched this webinar can talk to their GP about, what do you do when someone shows signs of hearing loss, and are you aware of a cochlear implant? And the programs in New Zealand, the Southern Cochlear Implant Program and the Northern Cochlear Implant Program that support people who need cochlear implants.
Yeah, and that was a nice sort of segue into what we're going to be discussing, Holly, because it's like with other standards of care in the health industry, they don't only guide clinical best practice, they guide health policy as well. So at a grassroots level, then we've also got at another level as well. So really, what would you both like to see, like from here? What does New Zealand have to do to meet the needs of adults affected by severe and profound hearing loss who may benefit from a cochlear implant? What, in this next 5 to 10 years, how would you like to see it moving as a program meeting those needs? That's a big question, I know, but yeah.
But I think we have to identify the need first. So we have to have a good accounting of what the population is out there, who are they, and how do we know, how can we plan to help them? So that's where that referral is so important. We've got to identify this group first, and then again we have to be advocates. And I think it is about funding. There's no question that funding is key, but there are some alternatives. And if you're fortunate enough to have to be able to privately fund, and you're at a stage in your life where you're making decisions about how you want to spend the rest of your life, think about that quality, and it may be that a privately funded implant might be well worth it to you or to someone that you love, it's good hearing. The benefits of good hearing are just so pervasive.
Yeah.
You said we need to identify the population. I think that's true, but we know that we've got a big population. We haven't, of people waiting already. And we know from the sort of international numbers that there are far more out there that we don't know anything about. So I think this needs to continue as a parallel effort. So the sort of people looking after the funds and funding from the Ministry of Health have to do their job, and we have to do our job to spread the word, you know. And I think it's going to take a while yet, but we've made big differences over the year, but there's still a lot of work to be done, you know.
And it's just great, I think, in New Zealand to see the cochlear implant community and hearing loss community working so collaboratively together, working towards this goal of better access, you know, so we are meeting the needs of adults in New Zealand who really need a cochlear implant. I mean, Michel and Holly, have you any final sort of comments before we sort of go into the, I think there's been a few questions have come in that you might note on the Q&A there. Have you anything else to add before we actually jump into Q&A and chat?
I guess I just would love to acknowledge the team at the Hearing House and the Northern Cochlear Implant program. We are funded by the ministry, but we do a lot of charity work, or we have to do a lot of fundraising to supplement the program. And one of the big events that we have is Loud Shirt Day, and that's going to be on October 23rd this year, and hopefully we'll be in a better position than we are now to celebrate that and raise funds around that. But the Hearing House is always trying to be very resourceful and inventive about raising funds for different programs for different populations. And it really does, it is a public-private partnership. And so just wanted to make people aware of that and just to express gratitude to the team at the Hearing House.
Oh, thank you, Holly. Michel?
I think it's just sort of repeating what we said here. I think the key point here is awareness, and I think we just need to spread the word, and any help is going to be helpful. So anything you can think of, just spread the word and let the whole of New Zealand know that this is available, and it should be available to all. And unless we know all of you who need it, we're not going to move forwards with this.
Well, thank you. Well, there's a couple of, the chat functions work, and I can't seem to get the Q&A function working. So it's like technology's not liking me this morning, I have to say. So I've got one question in from an audiologist here. Can you recommend any testing that we can do in the audiology clinic, i.e. aided testing, and which tests, and is there a test that I can do when we do not have a sound field?
Ollie.
Ollie.
Okay, so if you can do sound field testing, you know, if your client is performing less than 50 to 60% on a word list in the sound field with best fitted hearing aids, I mean, as a general rule, that means that they're going to be, they're getting about half of the information through their amplification, then they probably very well could be a candidate. So we do some word testing, we do sentence testing as well. But I think in New Zealand, if in the general clinics, if you do the PB Max score, which I think is the typical way of assessing people with insert earphones, you know, anyone who's showing a score, I would say below 60%, you should refer. If you can test them in the sound field, that would be helpful. But if your client's at that point, I guess I would encourage you to refer anyway. At least make the information available to your client so that they can start to learn about it.
Thanks, Holly. And I've had another question through the chat function. So please use the chat function if you have got questions at the moment. So this is from a consumer. Nikki asks, could we investigate the effectiveness of establishing a national referral/inquiry portal? This could operate at 2 levels: A, consumer and public; B, professional, ENT, GP, audiologist. This would aid discovery that you refer to, Holly. So that's quite a big, yeah.
Yeah. So. Yeah.
Bit of another time.
Yeah, it's probably a long discussion. I was just looking at the chat question here myself, trying to sort of parse out what that meant, what they were regarding. Effectiveness of the National Referrals Equity Portal. Well, I think it's a great idea, and I hope that Nikki will contact me and we'll talk more about it.
Great.
Yeah.
Great answer, Holly. And so has anybody else any other questions for Michel and Holly at the moment through the chat function?
You want me to answer that COVID question?
Yes, please answer. Yeah, the COVID, that would be a good one for you to.
I think the question is, how has COVID impacted cochlear implantation? And the answer is not much. I think just see it as a 6-week holiday of all the surgeons, and we're all back. We've done some cochlear implants last week. We'll be doing cochlear implants this week. And yeah, it's sort of back up and running. You're not more likely to get COVID if you have a cochlear implant. Yeah, luckily with our incidence of COVID is extremely low in New Zealand, as you all know. There's going to be surveillance of this for the next year or so until we have immunizations available. But yeah, so the impact is very little.
No, thank you, Michel, for that. And it's I think there's another short question there. Holly's popped up in the chat function. It said, as an audio, the idea of a short questionnaire, maybe using a pre-existing one, or spatial qualities of speech by Gatehouse. Can you see that question, Holly?
Well, it's in the chat?
Yes, in the chat, yeah. The idea of a short questionnaire, maybe using a pre-existing one.
Yeah,
Kim.
an audiology student thesis. That sounds like a fantastic idea. Yeah, I think again, it's about referrals, and I think most audiologists have questions and surveys or things they do to validate their hearing aid settings. That's the best practice to do that. And a lot of those questionnaires that are already being used, if you have someone who's not demonstrating benefit with their amplification based on that qualitative assessment, they should be referred.
Thanks, Holly. And then one from Carl, and he's made a very valid point here. You know, core funding has not increased over this last 10 years as far as he knows. Our current strategy has not worked in raising that funding. Do you think we need to change approach and perhaps couple with other disabilities in approaching government for funding? What are your thoughts?
Well, I think that's a question for the trust.
Yeah. I think it's yeah, collaborating as a sector. I think the disability funding hasn't increased much either over the years, so it is about, you know, working collaboratively with others, you know, in the area and to improve health outcomes for clients. Absolutely. So we've one in from a hearing therapist. I think we'll take one or two more before 12 o'clock finish. So as a hearing therapist, I've worked with a number of CA clients, but I do have concerns on how to best support those that have been turned down and who have no funding options, which is an issue really for quite a few. What do we do in that regard?
That's it is very challenging, and New Zealand is so fortunate to have the professional group of hearing therapists that we do have. It's really not something that you see in a lot of countries. And so, you know, having that specialized support, and they're all trained to sort of maximize whatever communication options a person has. But at some point, you know, if you don't have sufficient hearing, you really struggle. And again, sometimes these people may have other health conditions that are also impacting. So, you know, I think those folks know what they're doing in terms of providing additional written and visual information and using any kind of assistive device that we can to help alert them and be safe in their home, using safety equipment to protect them from fires, and you know, alerting systems to let them know when there's someone at the door, or if there's, you know, even there's the group of those who have hearing dogs that can help out, you know. So there are a number of different avenues, but of course the best is better hearing with a cochlear implant. So I think we've just got to really redouble our efforts and make this in some ways it's a human rights issue in many ways, this accessibility. So I think again, raising awareness is the call to action right now.
You know, and there is a petition actually online at the moment, you know, that Lewis Williams, the CA recipient and an academic, put out, you know, calling on the government to, you know, increase access for cochlear implant funding for adults. So, you know, people can help by actually going on and signing and sharing that petition, because we really would like a Health Select Committee hearing on that, and we need 5,000 signatures. So I think we're just over 3 at the moment, so people can help in that way in relation to the funding. So it is continuing to advocate really well. Well, look, I'd like to thank both Holly and Michel, both of you, for joining us today and giving up your time. It hasn't just been today, it's been the planning to bring all this together. It's been very insightful. We really appreciate everything you do for clients and the hard work on your dedicated teams that in the sector. And yeah, I can't thank you all enough for joining us this morning. And for everybody that has attended today, thank you so much for tuning in as well. We will be making this recording available in post-production, and it will come online in a couple of days, so you will be able to share it with colleagues that might have missed out. Yeah.
Thanks for organizing, Nick.
No worries at all. It's been my pleasure. Technical issues and everything, so thank goodness I've got 2 very intelligent people on the webinar this morning who could problem solve the IT issues. And yeah, so thank you all very much.
Thank you. See you later.
Bye everybody. Enjoy the rest of your day. Bye bye for now.
Bye bye.